Hi guys. So yesterday I was on call, so I couldn't do part 2 of this acute rheumatic fever. So but I've decided to quickly do it before I go to work. So we spoke about moving from pharyngitis to acute rheumatic fever. So we did emphasize that this is a primary infection, and then 2 to 3 weeks later a patient might present with the signs and symptoms of acute rheumatic fever. And we spoke about that this, for someone to progress from here to here, is because they were either not treated for their pharyngitis or they were inadequately treated. So, and we spoke about, so you get this, so the body develops, so now you've got an antigen in the body. Now the body develops antibodies against that antigen. So these antibodies are meant to attack this antigen. And the main thing that they target there is the M protein in the bacterial cell wall. And this M protein happens to be similar in structure to some of the body tissues. So now, because of this molecular mimicry and cross-reactivity, the antibodies do not only attack this, but they also attack body tissues. And we said that the body tissues that are normally affected is the brain, especially the basal ganglia. That's how they get the chorea, Sydenham's chorea. The heart, spoke about that, carditis. So they get carditis, which can manifest as CCF or mitral valve. It can either be early on, it can be, so let's just say a murmur in the mitral valve, because it can either be a mitral regurgitation and later on a stenosis. So it can also present, but we're not talking about, so the skin, and we spoke about the joints. I don't want to talk about glomerulonephritis at this point. We're going to talk about it after this, as maybe as part 3 of this. So this is what we're going to talk about now. So we did cover this, but I was just trying to bring everyone on board. So now we said the presentation would be someone who's between 5 and 15 years who present with a migrating or migratory arthritis or arthralgia, and the history would be they had a throat infection, a sore throat 2 to 3 weeks ago, or they might have had a scarlet fever, or they might not have had any of this, but they still have acute trauma, because they say some of these are subclinical, this pharyngitis, but then the patient still gets. Yeah, so now the way of diagnosing acute rheumatic fever, they use this Jones criteria. And in the criteria, for you to make the diagnosis of acute rheumatic fever, you need 2 measures on this criteria, or 1 major plus 2 minors, plus this has to be there, evidence of recent streptococcal infection, which we're going to talk about it now. So J is joints. This is major criteria. J is joints. So you've got arthritis that we said it's migrating from one joint to another, and it involves the big joints. Big joints, ankle, knees, elbows. They don't speak about the hip here. So yeah, and we said this is carditis, and this is subcutaneous nodules. So these nodules, I've never seen them, but they say it's like bumps that develop around the joints. It's like bumps that you can feel. Sometimes they're even, on inspection, you can still see them. And then there's this thing called Erythema Machinatum. Erythema Machinatum and Sydenham's chorea. Ham's chorea. So this is one word. Ham's chorea. So this is your major. These are your majors. And then now, for your minors, is basically so the patient must have fever, arthralgia, a prolonged PR, so which means you need to connect this patient to an ECG, a raised CRP or ESR. Some people always do both. So this is your minor criteria, and this is major criteria. And this is major criteria, and then we have evidence, because we said to make a diagnosis you need two of these plus evidence of streptococcal infection, recent streptococcal infection. It's two of these plus evidence. So the evidence is you can do a throat swab culture. Number one, you can do an anti-streptolysin O titers. You can also do an anti-DNAs. So these are your tests that you can do for the evidence. So to make a diagnosis, you need these. So you can either have two of these plus one of these, or you can have one of these plus two of these plus this, but this one of these must always be there. One of these has to be there to prove that this is really streptococcus. This is the only way you can prove that this is really streptococcus. So that's your criteria. So you can have any combination. It can be this or this or this or that or this or that, as long as it's two here plus one of these, or it's one here plus two here plus one of this, then you can make your diagnosis. So major criteria: arthritis, that is migratory, involving big joints, evidence of carditis, subcutaneous nodules, erythema machinatum, Sydenham's chorea. Chorea is like your involuntary movements that are purposeless. Our lecturer used to say in medical school that if you don't know what chorea is, just go and watch how Michael Jackson dances. So fever, arthralgia. Remember, this is arthralgia. This is arthritis. Arthritis. Arthralgia, a prolonged PR, a CRP, or ESR that is elevated. Throat swab, anti-streptolysin O theta, anti-DNase antibodies. So that's what we need. Anti-DNase antibodies. So that's what we need, ne? So that's your Jones criteria. So now, that patient, that 14-year-old that came with joint pains and all of that, so which means that they came when they are, let's say they are 14 years, and we asked the history, blah, 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 blah. But now we come to diagnosis. So we found that, okay, we are suspecting acute traumatic fever here. So we've done the examination. So which means we've got labs in terms of investigations, and then we've got imaging. So the labs, do FBC, do your basic bloods. Just do your basic bloods. Do your CRP, do your ESR, do your ASO, do your and then the imaging, chest X-ray, ECG. When they've got carditis, they will definitely need an echo, cardiac echo. So basically that's that. Or your throat swab, but this has got to be, I love this one. Sorry. So yeah. Okay, basically I'm trying to rush this, guys. Not sure if I'm forgetting anything. Sorry. I'm not sure if I'm forgetting anything there. Okay. Okay, I would really like to believe that I'm done with this. How do you treat? The management, obviously, if the patient comes in heart failure, you need to stabilize the patient, put them on monitoring, give them some diuresis and all of that. If they come in with in failure. But stable patients, what is needed here? You need to eradicate the infection. The goal. Eradicate the infection. Number 2, control pain of the joint. How do you eradicate infection? You give antibiotics. Which antibiotic? Antibiotic of choice is penicillin G. Benzathine penicillin. As a single dose. If you don't have that, you can go for PEN-VK. Course of 10 days. If a patient is allergic to penicillin, you can go for erythromycin. So these are antibiotics of choice to try and eradicate the infection. Then how do you control pain? NSAIDs are your drugs of choice. Most studies use aspirin. For those that do not respond there, or they've got other problems related to aspirin, maybe ulcers, whatever, you can give them steroids too. Or you can give them NSAIDs and give them PPIs like omeprazole, lansoprazole, things like that. But this patient, so that's that. That's the management, and obviously you need to talk to the pediatricians and see what else needs to be done. Especially after the echo, they will tell you how, because the echo is very important to decide, is the heart involved and how severely is the heart involved? Does this patient need surgery? What do they need for valve repair? All those things. So they will decide. One thing that I want, before I leave, that I want to talk about is how do you prevent this? So I spoke about not treating or inadequately treating pharyngitis. What was I talking about? I know this is a very difficult thing, and I've seen that people are really struggling doing it. When you have a patient with a sore throat, when you've got a child with a sore throat, a patient with a sore throat, to adequately treat them, to make sure that they don't develop acute traumatic fever, they must be, when they've got pharyngitis, they must be on PEN-VK. It's per kg, right? For 10 days, or amoxicillin. Actually, amoxicillin is for kids, this one is for adults, for 10 days. 10 days to adequately treat it, to prevent acute traumatic fever. 10 days, guys. The duration must be 10 days. Okay. So, if now you have someone, so this is like a primary prevention. But if now the person had acute traumatic fever, and then you want to do a secondary prevention, so they don't get recurrent acute traumatic fever, what do you do? there are different protocols that people are following, but the most important thing is that these people, they need to be on benzathine penicillin injections, which is about, it's according to weight. Some say less than 30, some say less than 27 kgs, but these ones that are less, they need 6,000 units of benzathine penicillin every 21 to 28 days. This is like a monthly injection, and the duration depends on if they didn't have carditis when they're diagnosed with acute rheumatic fever. It can be up to 5 years. If they had, or 18 years, whichever is longer. So if this person is 14 years and you want to put them on this, then you're going to take 5 years, because if they're 14, in the next 4 years they'll be 18. So you want to take them the longer one. So if they didn't have carditis, you can put them for 5 years or up to 18 years. So for someone who can't take benzathine penicillin, they are allergic, another choice is PenVK, 250 milligrams per os BD, same duration. That's the second option. But it is advised that this has got a better outcome compared to the other drugs. Or you can give erythromycin 250 milligrams per os BD, same duration. Now things changes when someone has got had carditis. It also changes when someone did surgery, or they've got RHD, proven RHD, they did surgery. So this one is lifelong with these ones, lifelong. With carditis, I think it's up to 21 years, but I'll confirm this, guys, ne? And I also need you guys to go and confirm these, but this is how it is. Secondary prevention, benzathine penicillin, 5 years or 18 years duration. With if there are more than these kgs, they get 1.2 million units for 18 years, up to 18 years, or for 5 years. Alternatively, PenVK. Another alternative to PenVK is erythromycin. That's if there's no carditis. But if there's proven carditis, it's up to 21 years. I'm forgetting another one. Because there's another one there. It's up to 21 years. But if they've done surgery, it's lifelong. So that's acute rheumatic fever, guys. Which we're gonna talk about post-streptococcal glomerulonephritis. If I've left anything, I will make a comment and pin it so that you guys can see. Thank you. Let me go to work now.